So on behalf of the UC Health Weight Loss Center, I'd like to welcome everybody to Westchester Hospital. My name is Susan Bethart. I may have spoken with some of you on the phone in the past. I am one of several dedicated patient advocates that are going to help you through your weight loss journey. So again, welcome. I am going to ask you to please silence your cell phones if you don't mind. We got a lot of material to cover and it would just cut down on the interruptions. And then I know you're going to have a ton of questions along the way. Go ahead and hold your questions till the end. The chances are whatever your question is right now will be covered in the slide 3 minutes from now. So if you don't mind doing that, that would be great. So we are going to go ahead and get started. What we intend to cover tonight is just 3 basic things. We're going to tell you about the UC Health Weight Loss Program. We are going to talk a little bit about UC Health as a whole, hopefully to ensure you that you've chosen the best weight loss program. And then, of course, those questions at the end. So how many people here have UC Health physicians? All right, good deal. So you're pretty familiar with UC Health. UC Health is essentially made up of 5 major entities. The first being the University of Cincinnati Medical Center, or University Hospital, some of you may remember it as. They're kind of our mothership. And then we've got Westchester Hospital, which is a community hospital. We've got the Daniel Drake Center for inpatient and outpatient acute rehab. I usually have a couple of people in the audience who have been down to the Drake Center for one reason or another. Do we have any of those tonight? No? Okay, yep. All right. Great place. The Linder Center actually partners with us for our psychological mental health aspect of our program. They've got a really good eating disorder program over there. It's a really great place. And then, of course, the University of Cincinnati Physicians, which, as you can see, is over 850 physicians strong. And then one thing that I think is important to note here is our commitment to our bariatric research. We've got a large group of scientists studying weight loss and weight loss surgery. So that's UC Health. This is a little bit about our practice. We essentially have 2 tracks. We've got our non-surgical weight loss, and then we've got our surgical weight loss. Obviously today we're here to talk about surgical weight loss. Both programs incorporate a multidisciplinary approach to weight loss. So when you're calling us and you're saying, I want to make an appointment for weight loss surgery. Well, that would be great, except you won't be successful if you just call up and you get an appointment and you have weight loss surgery. We have you meet with the dietitian. We have a behavioral health expert that we work with that you will meet with. We have fitness experts, and we have our patient advocates that help you along the way. And we feel like these are all very essential components to making sure that you are successful in whichever track you decide to get into. And then Dr. Fitch here is a certified bariatrician. She manages our non-surgical weight loss program. And then, of course, we have Dr. Brad Watkins and our esteemed Dr. Jonathan Thompson here with us today. All of our services happen here in Westchester. Your office visits will be at the Westchester Medical Office Building here on this campus, and then all of your surgeries themselves will be at the Westchester Hospital. Westchester Hospital and the Westchester Surgical Hospital is also MBSA QIP accredited, and this essentially is a group of doctors and scientists that and surgeons that put out the criteria for a center of excellence. And if you meet those criteria, which UC Health does, then you get this accreditation, which is a pretty big deal. At this point, I am going to turn the presentation over to Dr. Thompson. He is going to give you all the technical components of the surgery. And then when he's done, I'll come back and I'll tell you a little bit more about how to get started. Thank you.
Thank you, Susan. So I'm all mic'd up because we are recording this so that you can watch it online at your leisure. So I think it's very important, Susan touched upon this, but weight loss surgery is a multidisciplinary specialty. So it's not just fantastic surgery that you sign up for. You sign up for changing your life. And it starts with the idea that you have to form new habits. And I'll explain that in a little bit, but it's a very important point to drive home. That it's new habit formation that we sort of preach throughout the entire process. And the anatomy that we help achieve with the surgery just gives you an anatomic advantage to help resist the world as it stands right now. So I'll get into a little bit more of that, but the obesity epidemic is an important thing. The US is #1 in the world for obesity. It's now the leading cause of preventable death in the United States over smoking. And so more than 65% of adults are overweight or obese. And so when you think about that on the flip side, if 65%, or it's really near 70, but if 70% of Americans are overweight or obese, that means being normal weight is not normal. So I'll say that again. Being normal weight is not normal. Obesity is an environmental disease more than anything else. And so if you think about it, how many people pass more than 5 fast food restaurants on the way here? So fast food is not the problem. It's a symptom of the underlying problem, which is that our culture has sort of evolved over time to love this cheap, terrible food that's everywhere. And so ultimately, that's the problem. That plus the sedentary lifestyle, and everybody's used to it. And so that's why obesity is an environmental disease. And so there are genetic and behavioral components, right? Not everybody, it's not 100% of Americans are overweight or obese. And so some people have genetic resistance. Like, I'm sure everybody knows somebody that can eat whatever they want and are still skinny, right? So that's, some people have genetic resistance. And then others develop behavioral strategies to resist the cheap, terrible food that's everywhere, and have strategies where they exercise every day and they live an active lifestyle. So ultimately, you can resist this cheap, terrible food that's everywhere and resist the environment. But a lot of folks, once they get to the point where they are morbidly obese, cannot lose weight on their own. So surgery is about 90 to 95% successful in helping you lose weight, and not having surgery is 90 to 95% of the time you'll fail to lose weight. So it's very important. So I can bore you to death with all these statistics, but just know that obesity is a big problem, and I'm sure everybody is aware of this. It's a multi-factorial problem, so we've uncovered some genetic components to this. Everybody understands sort of the environmental and the societal components of it, but obesity was not an epidemic in 1950, and it's an epidemic now. So does that mean that it was a genetic thing? Was it cosmic rays? Is it that we all have mutations now and now we're all obese? No, the environment changed, the culture changed. And so this is sort of an example of, the cheap, terrible food that's everywhere, high caloric density food. This is the same number of calories, so this is unhealthy, and this is healthy on this side. There is the same number of calories in each one of those sort of portions of food. So ultimately, this is sort of the typical American diet. Our veggies and whole grains and other healthy items, the stuff that everybody eats every day? And the answer is probably not. Also, the sort of portion distortion. So it's not just the type of food, but portions have grown dramatically. So here's a comparison of the sort of 80s versus the 2000s. So a bagel is about twice as big as it used to be. A muffin is about 3.3 times what it used to be. French fries are about 3 times what they used to be. And a regular chocolate chip cookie is about twice as big as it used to be. And I'm sure everybody sort of has experienced this. It's the supersize me phenomenon. But again, fast food is not the problem. It's a symptom of the underlying problem. So obesity and normal weight and everything else is judged by body mass index. So you shouldn't weigh the same if you're 3 feet tall and 7 feet tall. And so body mass index, it indexes your weight to your height. So ultimately, we go by the numbers. So normal weight is 18.5 to 25. So underweight is under 18.5. So overweight, 25 to 30. Obesity starts at 30. But then severely obese, this is where you start to qualify for weight loss surgery if you have diseases that are related to your being obese. And we'll get into those. And then as a raw number, 40 is considered morbidly obese or class 3 obesity, and that also qualifies you for weight loss surgery. So we think about obesity as a whole body disease. It's an inflammatory state. It increases your risk of certain types of cancer. Everybody understands, or most people understand, that it increases your chance of heart disease because it does increase the chances of you having diabetes, dyslipidemia, hypertension, which are all risk factors for that. I don't have to go through the laundry list, but just understand that it's a whole body disease, and by treating the obesity, most of these things go away, or the risk is reduced. So there's some health benefits to losing weight. So if your BMI is greater than 30, you have a 55% increase in mortality, that's dying, 70% increase in coronary artery disease, 75% increase in your chances of stroke, and 400% increase in diabetes. So all of these things are directly related to weight. And losing weight does reduce your risk of a lot of these things. So weight loss surgery can also save a lot of money, right? Because you're reducing your disease sort of load. So the grand total ends up being about $18,000 a year if you add up all of the expenditures on health and the cost of diets and things like that. So we don't treat everybody the same. Weight loss surgery is indicated for the most severely obese patients. So if your BMI is 35 or greater and you have comorbid conditions that are directly related to your obesity, then you qualify for surgery. Or if your BMI is greater than 40 is a raw number, you qualify for surgery. This bears repeating, that's why I'm saying it over and over again. But the bottom line is we don't treat everybody with surgery. So pharmacotherapy, that's drugs, and specialized diets are indicated when you're overweight but not obese. And so when you have comorbidities, and when you're obese but class 1 obesity. And then lifestyle modifications when you're overweight but not obese. So ultimately we think about it as a pyramid. So if you got to lose 10 or 20 pounds, you probably shouldn't have surgery. You should probably tweak your diet a little bit and exercise a couple times a week, right? And so we sort of go up the ladder. If you have to lose 100 pounds, the odds of you tweaking your diet on your own and exercising a little bit more each day, probably not going to cut it. So this was a landmark article. It's the Swedish obesity subjects group. So the bottom line is they followed a bunch of patients that had surgery and matched them with controls that did not have surgery, and they followed them over time. So that's 16 years. So the median follow-up was 10.9 years, and pretty much everybody followed up. So when they looked at it, in the patients that did not have surgery, they died with an adjusted mortality. So they had an adjusted mortality of 29% more. So they died 29% of the time more frequently than the patients that had surgery. So surgery saves lives is what I'm trying to get at. And the most frequent cause of death was cancer and heart attack. Does that make sense to everybody? I'm sorry, I still haven't figured out how to communicate that very well, but having surgery reduces your chances of dying of cancer and heart attack. I think I should just lead with that next time. So, surgical options. We're here to talk about surgery. Very important thing to remember about surgery is that surgery is not a magic bullet. You don't wake up skinny the next day. You don't wake up having this dramatic desire to go to the gym. You don't wake up with different food on your mind. It's not like you wake up and you're dreaming of celery and all these other things that are healthy for you. It's hard work to go through the weight loss surgery process. And so it's not an event, it's a process. The surgery gives you a tool. It's all in caps, and it's bolded, and it's red, and it's underlined. It's a tool. It's not a magic bullet. But it's a powerful tool. It does make losing weight a lot easier. It makes you feel full on a small amount of food. If you have a sleeve gastrectomy, it makes you feel less hunger. A lot of patients, we get the story that, you know, I've lost weight. I've lost over 100 pounds at one time in my life, and then I gained it all back, and then some. And I lost it again, and I gained it back. And so when these patients have surgery, they lose it because they have the discipline to change, but then they lose it forever. And so that's the power of surgery. And there's no magic way to lose weight. This is a hard process. And that's why we have the multidisciplinary team here for you. I've already talked about the candidates for surgery, but again, I'm going to repeat it. So BMI of greater than 40 or BMI of greater than 35 with comorbid conditions. And the lap band for the self-pay crowd is indicated by the FDA for a BMI of greater than 30 with comorbid conditions. Everyone in this room, I guarantee, has failed medical weight loss attempts. I guarantee it. But we will investigate that, your history and what you've tried. And then absence of drug or alcohol problems, it's very important. The thing is, we're going to take away a good deal of pleasure in your life when we do the surgery and as you go through the recovery process. And so patients that have a history of substance abuse or active substance abuse will sort of transfer that sort of pleasure and try to seek it somewhere else. And so it can sort of trigger relapses if you have a history of substance abuse or an increase in your substance abuse. So that's why we screen for that, and we make sure that it's treated before we will do your surgery. And then we have a multidisciplinary team. So we have a case conference every other week, and we make sure that every patient is discussed. All red flags are sort of vetted through all of our team members, and we come up with strategies to fix them. Patients must understand the surgery, exactly what it entails, and the risks. Otherwise, you don't really have informed consent. And so we spend a lot of time talking about the surgeries and exactly what it's going to be like after the surgery. We're going to say it again. You have to be dedicated to making a lifestyle change. So this is an operation to help your brain get better, to help your habits, to help you live a healthy lifestyle. We give you an anatomic advantage and a powerful tool, but it takes a lot of hard work. So surgery is safe. That's what this slide is trying to tell you. This is a bunch of different studies that were done over the years, sort of lumping all bariatric procedures together. This is mortality rate. So these are old studies from sort of like the 90s. And basically the mortality rate or the death rate is less than 1%, even with the oldest studies. Currently, the mortality rate is in the fractions of a percent. So, 0.1 to 0.5%. So the bottom line is it's safer than a lot of these routine surgeries. So hernia surgery, appendectomy, surgery for GI obstruction, laparoscopic cholecystectomy, which I'm sure a bunch of you in this audience have had already, and then a bunch of others. But the bottom line is bariatric surgery in 2015 is a safe, routine surgery. There's a lot of misconception about bariatric surgery, that it's radical and risky. And in 2015, it is safe and routine. So we do laparoscopic surgery. It is very, very rare that we have to convert to open surgery. Sometimes for crazy revisions, we have to go straight to open surgery, or complications, we can go to open surgery. But all of our surgeries are done laparoscopically, which means that we make small holes in your abdomen, blow your belly up with gas, and stick a camera in, and do all of our surgery using a video screen and long instruments. So what that means is less pain, quicker recovery, quicker back to work time. The types of surgery that we do, lap band over here, sleeve gastrectomy, which is going to be the vast majority of the patients in the room will get a sleeve gastrectomy, and gastric bypass. So we do 90+% sleeve gastrectomy, and that's where the entire bariatric community is going. So in 2014, on a national basis, the United States, 55% of the procedures were sleeve gastrectomy. So bands was about 5%, and gastric bypass was in the 30% range. All right, so the gastric band. So we don't show the abdomen, we're just showing this. So these are our access devices. It's called trocar. That's the band that we place inside the abdomen, put her on the top of the stomach, basically creating a little pouch at the top of the stomach. And there's some tubing that goes out to your abdominal wall. That tubing is then connected to this port. And then food sort of gets held up above the band, just enough to stretch out that upper pouch and make you feel full. And then it proceeds normally along the intestinal tract. So digestion proceeds normally. Then we'll show you the needle, but the needle's big. So if you're afraid of needles, the lap band is not for you. I kid you not, there was a patient that came in wanting a band revision, so a conversion to sleeve, because the practice that put in his band didn't tell him that you have to access the port with the needle, and he was terrified of needles, so he never got it accessed. So we put these bands in empty. The whole idea is to adjust the amount of fluid over time so that you get to the sweet spot where food hangs up for just a little bit, makes you feel full, and goes through without a problem. So if it gets stuck, there's too much fluid in there. If you can't swallow liquid, there's too much fluid in there. If your pouch gets dilated, there's too much fluid in there. Alternatively, if you don't feel full on a small amount of food, there's not enough fluid in there. So it's one of those things where you got to come in every month for an entire year to make sure that we've achieved that sweet spot. It doesn't happen with everybody. And so that's the sort of variability of the band, is that not everybody achieves the sweet spot. Some patients go back and forth of pouch dilation, all the fluid out, then start to refill. Another pouch dilation, all the fluid out, then start to refill. And so ultimately, they never achieve the sweet spot, and they never really get the results that they were hoping for. So we do a lot of band to sleeve conversions these days. We probably do more band to sleeve conversions than we do band placements. So the attractiveness of this operation is that it's an outpatient procedure, meaning that you come in that morning you get surgery and then you leave the hospital. But again, we put them in empty. So you have to get it filled over time to get it to work. Return to work is 1 to 2 weeks. I mean, it really is, it could be even less than that. And so it is the sort of shortest recovery time, lowest risk of dying from the procedure, but it's the highest risk of reoperation. Up to 40% of patients need a reoperation, whether it be a sort of a port problem where your port can flip, the tubing can sort of rub down and get a hole in it, so we have to replace ports sometimes, or replace the band or take out the band. So 40% is that sort of risk number, not in our practice, but on a national level. And then adjustable removal. Some patients like the idea that they can be made to go back to normal. We put every band in thinking that it's going to stay in for the rest of your life. So the sort of removable thing doesn't really make sense to us, but we understand. And then disease resolution is very good. So hypertension, hyperlipidemia, diabetes, it's in the 50% resolution. Obstructive sleep apnea, 50% resolution. The disadvantages, the regular office visits. So once a month for a year is what you're signing up for. And then the sweet spot I've already talked about. You know, some patients don't like the idea that they can feel a port underneath their skin. Dilation is a very common thing. Port problems are very common. Erosion is uncommon. That's where the band will end up on the inside of the stomach, right? The band's wrapped around the outside of the stomach. If it ends up on the inside of the stomach, it's got to come out. That doesn't happen very frequently, but when it does, you need to go to surgery, so it's a big deal. All right, sleeve gastrectomy. So this is the most, again, the most common surgery that we do, but I think it's the easiest to understand, and it makes the most sense to me. So that's food. That mixes with digestive enzymes, that's the green stuff, or the yellow stuff, I guess it makes green. Bottom line is, when you cut off the stomach, which they'll do in a second, when you cut off the stomach, food progresses normally along the intestinal tract, and digestion happens normally, which is not like a gastric bypass. They're going to do it again. All right, so digestion happens normally. So the reason why this makes the most sense to me is your stomach is a big sack. The whole idea behind your stomach is that it enables you to eat a lot of food at one time. And then it can help grind it up and then make it progress through. The fundus doesn't really have a whole lot of muscle in it. It doesn't really contract. It only exists to stretch and let you eat more food. The body has a little bit of motility, but really stretches as well. And the antrum is the thing that grinds food and pushes it forward. So our targets in this surgery are the fundus and the body, and we don't care so much about the antrum. So we really are just removing your ability to eat a big meal. Makes a lot of sense. Also, when we look at the concentration of ghrelin-producing cells, ghrelin is a hunger hormone. I'm sure you guys have done your research on this. But when you do a sleeve gastrectomy, the ghrelin levels go down by about 80%. And so patients report less hunger. Some patients report zero hunger after the surgery. It tends to come back over time, but that sure does give you a jump start when you're trying to learn new habits and sort of live the healthy lifestyle. So we like this surgery a lot. So hospitalization is an overnight stay for the vast majority of patients. When patients have to stay, when patients have to stay another day in the hospital, it's usually because of nausea. Nausea is a very common thing after this surgery. We think it has something to do with the fact that we've just cut along the entire length of the stomach. So some patients have zero nausea, but most patients have a little bit of nausea that goes away in the first 24 hours. Some patients have nausea that lasts longer than even the first couple of days after surgery, and they have to be on antiemetics while they're at home. So it's something that we're sort of trying to get to a protocol on where, you know, we've got the right cocktail of medications to prevent it and then treat it. But it's just one of those things where most patients are out of the hospital after a day. Some patients have to stay a little bit longer. It's very reliable weight loss. So in a recent meta-analysis, which means that they looked at, so one researcher looked at all of the publications over a certain time period. So it was the early 2000s until 2012. Basically looked at the different weight loss surgeries and how they compared in patient outcomes. And so sleeve gastrectomy was equivalent to all of the bypass operations when lumped together. So I'll say that again. Sleeve gastrectomy was equivalent to bypass in weight loss when they looked at all of the published literature. So really, when you look at the different procedures and the risk profile versus the benefit profile, we as surgeons make risk-benefit calculations. And so we want to give our patients the most benefit at the least risk. Sleeve gastrectomy comes out on top for most patients, and that's why we like it so much. So no port adjustments. We've actually changed our office protocol. We used to see all of our patients every month because we were set up doing a lot of bands. But we found that a lot of these visits are unnecessary because our patients are doing so well. And so, you know, in addition to not having to do port adjustments, you don't have to come to the office every month after surgery. So that's kind of nice. Disease resolution is very, very good for the sleeve gastrectomy, more like the bypass than like the band. Leak is the most feared complication. 90% of the leaks happen at the very top after 7 days, so our patients are at home when they're at risk for a leak. The thing is, we think leak is a technical problem that is exacerbated by throwing up against an obstruction, and I'll tell you a story to exemplify that. So we've had one leak as a practice in over 400 cases, so our rate is very, very good. The story we've heard from other practices, this didn't happen for our patient, but the story we've heard from other practices is that patient feels great 3 weeks after surgery, is out at a family picnic, and they've got pizza there. And the patient eats a piece of pizza, takes a bite, doesn't chew it well enough, and that bite gets stuck. Usually when things get stuck, they get stuck right there, sort of at the turn. It's called the incisor angularis. And so your immediate response to something getting stuck in any part of your intestinal tract is to throw up. And so when you throw up against an obstruction, you create a really high pressure zone above that obstruction. And so that high pressure zone has to go somewhere, right? So you've got a high pressure column of fluid that can pop off the top of the staple line. That's the thinnest part of the entire stomach, and that's where most of the leaks happen. So we think that's how it works, and so that's why you're going to be on this restrictive diet after surgery. So it's a month of liquids, a month of mushy, and a month of soft food, and then whatever you want. Does everybody understand that you're going to be on 3 months of restricted diet after the surgery to prevent leaks from happening? A lot of patients don't like the fact that a portion of the stomach is removed, but again, I told you what the function of the parts of the stomach are that we're removing. It's to enable you to eat more food, and so we just remove your ability to eat more food. So we actually think that it makes a lot of sense. The need for nutritional supplements. So vitamin B12, that's the one. So your stomach produces intrinsic factor, which helps you absorb vitamin B12. And so we recommend sublingual B12 to prevent vitamin B12 deficiency. But it's not like a gastric bypass where you have to be on 10 different vitamins and minerals that are at high doses. All right, moving on. So gastric bypass, a lot of folks talk about this as the gold standard. It was developed in the 60s, changed to a laparoscopic procedure in the late 90s, early 2000s, and became very popular at that time. So basically we make a teeny little pouch out of the top of the stomach, divide the intestine, and then use that piece of intestine to drain the teeny little pouch, and then reconnect the intestine downstream. So that's where food goes. That's where the digestive enzymes go. And they mix farther on down the road. So there are two functions of the gastric bypass. Number one is that's a teeny little pouch. So it's a restrictive procedure first and foremost. Just like the band, just like the sleeve, you have a tiny pouch. And so you eat less food because you have a smaller stomach. And then it has this malabsorptive component because the digestive enzymes aren't mixing with the food until a lot farther down. But if I were to take that same amount of intestine and remove it from your body, your other intestine gets smart and it gets more efficient at absorbing things. And so the weight loss for the malabsorptive component is temporary. So most patients lose about 80%. So we track sort of success in weight loss surgery with excess weight loss. So if you're 100 pounds overweight, and so that's your weight right now, versus your ideal body weight. If you're 100 pounds overweight and it's an 80% excess weight loss, then you lose 80 pounds. Following me? So with the gastric bypass, at a year, you lose 80% of your excess weight. But at 3 years, you're down to 60% of your excess body weight. Does everybody understand that? So this sort of malabsorptive component wears off. So you peak, and then you gain some weight back. Totally normal with gastric bypass. And so that's why when we look at these surgeries, we sort of compare them after 3 years. And so after 3 years, sleeve gastrectomy and gastric bypass are equivalent. So this is the longest hospital stay. It's a bigger surgery, return to work 2 to 3 weeks. You know, the highest 1-year excess weight loss, but I already talked to that. You know, no band or poor disease resolution. So this is a true metabolic surgery. It changes the hormone profile. Your intestines might surprise you to find out that they are hormonally active, and those hormones are responsible for your glucose regulation. And so ultimately, patients can actually wake up from surgery with cured diabetes. This happens a little bit with sleeve gastrectomy, but not as pronounced as gastric bypass. The disadvantages, though, it's a laundry list. So ultimately, this is why we sort of come to the conclusion that sleeve gastrectomy for most patients, unless you have things that sort of preclude getting a sleeve gastrectomy, for most patients, that'll be our go-to surgery. And so I'm going to talk to a couple of these because they're life-threatening, potentially. So internal hernia and obstruction. So what we never show in these pictures is that all of this intestine is fed by a curtain of fat with blood vessels in it. That's called mesentery. So the bottom line is there's a curtain of fat with blood vessels in it that goes up and down there. And so the intestine can snake under that curtain of fat with blood vessels in it, and it can get stuck and that's called an internal hernia. Much like an abdominal wall hernia or a groin hernia, if intestine gets stuck out into an abdominal wall hernia, it's a surgical emergency because that intestine can get cut off from its blood supply and it can die, and it can perforate, and it can cause a disaster. So that happens without any visible sign that it's happening. You just have terrible abdominal pain that doesn't go away. Sometimes nausea and vomiting, but terrible abdominal pain. And so guess what? The only way to really know is to go back to surgery. And so if you have an obstruction and you have a gastric bypass anatomy, our go-to diagnostic is to take you to surgery. So we'll probably get a CAT scan first, but most patients will go to surgery. So it's about a 10% reoperation rate for internal hernia and obstruction, 10%. Marginal ulcer, it's a low rate, but it can happen, and it can be a disaster. So the part of your intestine that we swing up there isn't used to seeing raw food or acid. And so it can get an ulcer, and that ulcer can bleed or it can perforate. And I've seen a couple patients die from perforated marginal ulcer. It's a big deal. And so both of those things are sort of what I call ticking time bomb complications. You don't know who it's going to happen to, and it's a lifelong risk. And so completely avoided if you get a sleeve gastrectomy. So this is why we as surgeons like the sleeve gastrectomy. Greatest benefit at the lowest risk. So then this is just one surgeon series, but basically when you sort of follow patients out, lap band is about 50% excess weight loss. In this series, the sleeve was about 80%, and then gastric bypass was about 80% excess weight loss. But results vary on the patient. So these are averages. So some patients do not so great. Some patients do fantastic and have 100% excess weight loss. But most patients are in the middle, and this is what the middle looks like. All right, so we've already talked to the 3 stages: the liquid, the mushy, the soft. I think about it as straw month, anything you can suck through a straw; spoon month, anything you can eat with a spoon; and fork month, anything you can cut with a fork. The pre-op liquid diet has a completely different reason. So your liver is the temporary storage for calories of your body. And so every patient that's morbidly obese has a big liver, and that's in the way of what we need to get to in the surgery. So we have you do a liquid protein diet 2 weeks before surgery to shrink your liver and make the surgery safe and doable. Sometimes we can't do the surgery, and if it's not safe, we will not proceed. So the care plan and the program requirements, it's a long, arduous process. But again, you did not sign up for a single event, I'm going to have surgery and then go home. You signed up to change your life. And so that takes time and effort. So bear with us. Everybody has to be committed to the lifestyle and behavioral changes, otherwise we're not going to do the surgery. Important to point out that there is no carbonation ever after weight loss surgery. So in addition to carbonation, overeating after weight loss surgery will stretch out your pouch. That's just how it is. It's biological tissue. Has anybody ever seen one of those Discovery Channel shows where they sort of follow a competitive eater through the course of their day? Anybody? No? The little guys from Japan that beat the pants off the guys from Texas? No? Anyway, so how a competitive eater keeps their stomach huge is they eat one huge meal a day, and they just pack it in. Whatever they can get their hands on, they eat and eat and eat and eat until they feel that sort of full feeling, and then they eat a little bit more. And so when you think about it, it's the same basic biologic tissue. If you eat like a competitive eater and sort of fill up your stomach and then eat a little bit more, it'll stretch just like the stomach of a competitive eater. And so when you have a stomach that is 1/5 the size that it used to be, it's really easy to overeat. it's really easy to take that 1 extra bite or those 2 extra bites. And so a lot of this sort of control of your diet, it has to go from your sort of emotional brain and your old habits to the front of your brain, so the executive part of your brain. So you have to plan all of your meals before you start to eat them. And so the bottom line is, once you heal from your sleeve, we'll want to size your sleeve, so eat until you're comfortably full, and then remember what volume that is, and that just becomes your ceiling. So you put that portion on your plate, or in your bowl, or in your cup, or in your pocket. That's all you eat at one given time, so that you don't stretch out your pouch. So carbonation and then overeating, those destroy pouches. So which surgery is right for you? So ultimately, we have to look into your medical history. We have to have a conversation. We have to make sure that the surgery is right for you, and then we figure out which one will be the right surgery. All right, now I'm going to hand it back to Susan for the path to surgery, and then I'll take questions.
Thank you, Dr. Thompson. So pretty good stuff, huh? Who all's ready to get into the office and get started? Anybody? Yay! All right, great. Well, I am here to tell you how we're going to get that done. We basically have 3 types of patients. We've got self-pay patients over here. They follow one path. We've got insurance patients over here following another path, and then we've got a group of patients that will sometimes need additional clearances over and above what insurance requires or what our program requires. So essentially, this is what's going to happen when you come into our office. We do have a program fee, or a program enrollment fee. I want everybody to know that up front. When you schedule your initial assessment, we will collect actually $160 from you. $100 is for your program enrollment fee, and $60 is going to be for your fitness consultation, because we know that no insurance will pay for that. So that's a $60 fee. So that's the expectation on your initial assessment. During your initial assessment, you're going to have your baseline testing. That's going to happen. You're at another visit, you're going to come in and see the surgeon for a consultation. You're going to see our dietitian for a consultation, fitness of course, and then you're going to have a behavioral health evaluation. Depending on what your insurance covers will dictate what your additional fees are going to be. So when you come in, we're going to enter into a partnership. So with that partnership, we're going to have you sign a couple of documents. One of them is going to be that program outline that I just showed you. And we're going to go over it in detail so that everybody understands exactly where they are in the path. We're going to also have you sign a attendance policy. We do have an attendance policy here. And that's really just to avoid a lot of the no-shows that practices sometimes can get. And all that does is delay other people from getting in sooner when we've got all these times blocked for people that are no-showing. So we're going to go over this. We're going to assign that. And then we're also going to have you sign a code of conduct. And again, it's a partnership. When you sign up with us to do your weight loss surgery, we are going to be committed to providing you the best care and treat you with the utmost courtesy and respect. And in turn, we're going to expect that our patients treat our staff and our providers in the same manner. So together, we're going to sign this little agreement here. Dr. Thompson spoke a bit about the absence of alcohol and substance use. Very important. So I think it's only fair to let everybody know that in addition to the long bank of lab work that we're going to have drawn on you the day that you come in for your initial assessment, that we are going to have you take a urine drug screen. If it comes back positive, we will deal with that. We have a licensed social worker that will help you work through whatever issues you may have. But again, it's only fair to let you know that that's what's going to happen. So everybody goes through the program that we just talked about. The people who are having their surgery covered under their insurance are going to have to go through some additional things. Many times, insurance companies will have patients do a physician-supervised weight loss attempt. So some are 3 months, some are Medicare is 6 months, some of the other state-funded insurances are 9 months, even 12 on rare occasions. So you'll be expected to complete that part of the insurance requirement. They also may ask for documentation of a weight loss history, meaning you've seen a physician over the last 2 years, or you've been struggling with your weight and working towards weight loss for the last 2 years unsuccessfully. And then a letter of recommendation from your primary care physician. These are all things we will help you get. That's what our patient advocates do. You're going to have most insurance companies, and I will say this, our program outline mirrors what most insurance companies require. So most insurance companies now will require the psychological evaluation. We don't think you're crazy. We just know that this is a lifestyle, this is a life-changing event for you. You're going to change your behaviors, you're going to change your lifestyle. It's kind of a big deal. So we want to make sure that you are prepared for those changes. We may send you for a sleep study. We will do just a quick little sleep apnea screening on you, and based on that, we may send you off for a sleep study. And so again, these are what's not every insurance company requires all these, and they're all a little bit different, because I know the big question is, does my insurance cover this? And that, unfortunately, is the only question tonight that I cannot answer for you individually. We have insurance patient advocates that will help find out for you if you have coverage for bariatric surgery or not. So the next step is basically getting you into the office. You're here tonight. You've gathered all the information that you need to move forward. If you haven't filled out that 12-page medical history questionnaire, fill that out and you can turn it in the back, or if you haven't even started it, you can finish it at home and send it back to us. We'll need to have that information before we schedule your initial assessment, and then we'll get you started.